Hi, I'm Meg Callahan with Infectious Disease Special Edition, and I'm here with Dr. David Koren, who is a clinical pharmacy specialist at Temple University Health System in Philadelphia. And we're here to talk about HIV because you just gave a talk during a workshop about HIV updates. We're here at MAD-ID SIDP 2026.
Thank you for having me.
Yeah, thank you for talking to us.
My pleasure.
So what's new? What did you talk about in terms of treatment and PrEP?
So this is a very, very exciting time in HIV. We had been through some difficult times within the year prior about not knowing what the future was going to hold, some funding cuts, things of that nature. But I think the real word to describe this past year, both on the treatment and the prevention side, is pipeline. And I'm a pharmacist, so that's a really exciting space for me to be in. We've already seen a brand new combination product for people who are living with HIV. It's a way to be able to kind of simplify therapy, if you will. But this is just the tip of the iceberg. And we're really seeing a lot of combination therapies and individual agents coming down the pike, one later this year in 2026, another in 2027, for people who are living with HIV to give them options. And I think that that's where we really are in HIV, that we have the benefit of riches, that we have so many developments and that bar has gotten higher and higher through the years, that we are able to simplify medication therapy, reduce pill burden, in so potentially reducing stigma as well, because we now have long-acting injectables, which I know we're going to talk about a little bit, but also we're going to have long-acting orals where people are able to take pills not even once a day anymore. On the PrEP space, we're even in a bit of an arms race at the moment. And so our really, really wonderful options, which have extraordinarily high efficacy, are just getting better. We're seeing different injectable options extending their half-lives. We're going to every 4 months or even once a year. And we're going to have a long-acting oral option as well. So potentially even once a month for people who don't want to take injections. So I think the pipeline and choice for patients.
So let's talk about some of the new orals first before we go to long-acting.
Sure.
So there was just an approval.
Absolutely.
So what was that one about?
So this is the approval of two medications together, and this was from Merck, the combination of doravirine, a second or sometimes people call it a third generation non-nucleoside reverse transcriptase inhibitor, and that is combined with a new, what is being called by the FDA, still a nucleoside reverse transcriptase inhibitor. This is called islatravir. Islatravir has had kind of a complicated story in HIV. It's been around in development for quite some time, but in 2020, right before the pandemic, if you will, there was a complete hold on the entire clinical trial program because of significant adverse effects. And people's CD4 counts, even those with healthy CD4 counts, were declining. And so needed to stop everything, go back to the drawing board and figure out what happened, why it happened, and how can we fix it if it was fixable. The good news, if you will, is that it was found that this was a dose-dependent relationship. And so by fixing the dose, you were able to, if you will, fix the adverse effects. And that's what we ended up seeing in the 051 and 052 Merck clinical trials, which got this medication approved. So right now, doravirine and islatravir is approved for people who are suppressed on HIV treatment as a potential switch option. Unfortunately, it can't be used in absolutely everybody. It does have a cutoff by FDA standards. Can't be used with people with significant renal dysfunction. Creatinine clearances of 30 or below is not approved. But we do have, again, doravirine and islatravir, and I was mentioning before that it is a nuke, but I'm calling it, I mentioned in my talk, it does have additional mechanisms of action. I'm calling it a nuke with spice, if you will, because it does affect translocation as well within reverse transcriptase. So it affects some movement as well as creates a kink in the chain. So additional mechanisms beyond the nukes, but it's still working at the same site. So therefore, it was deemed by the FDA still a nuke at the end of the day.
Very cool. And then there's some other, we were actually at CROI, we talked to some other people about another drug that's coming down the pike, Biclen.
Yes.
So could you talk a little bit about that?
Yeah, so bictegravir, a integrase strand inhibitor, which we know and love, and lenacapavir, which is approved not only on the treatment side, but also the prevention side. So lots of people getting used to this. So this, again, is another oral tablet, going to be taken once a day. Gilead did receive their PDUFA date, so we are looking at a potential decision by the FDA at the end of August. So an option potentially for our patients by the fall, by the time it gets to the pharmacies. And And this was studied in the Artistry clinical trial program. And so what I really liked in the way they designed the clinical trials is that we know that the HIV cohort in the United States is aging. And so what happens with aging, which is a potentially good problem to talk about in the field of HIV, because we didn't have this to talk about 30 years ago, is more comorbidities. And, again, as a pharmacist, what do I hear when I hear more comorbidities? I hear more medications and more predilection towards more drug-drug interactions. And so if we're able to reduce the pill burden on our patients, potentially getting them from complicated regimens, the amount of time people had been living with HIV in these clinical trials was more than a decade. And so people had been through multiple options, were on complicated regimens, and were potentially able to get them down to one pill once a day. And so they were able to show, just as we showed in the previous with the previous combination product, non-inferiority with baseline regimens. So it's going to be another very exciting option to be able to, again, reduce pill burden for some of our patients who are taking multiple tablet regimens with multiple drug-drug interactions.
So what else is coming down the pike in orals?
Further down the pike, I think we're going to see in 2027, we've already started the clinical trial development program we talked before about islatravir, and we talked about lenacapavir. So if you put ISL and len together, you get the ISLEND clinical trial development program. And this is really exciting because, as I mentioned before, it's going to be our first long-acting oral therapy. And so they are currently studying once a week formulation. We did see some good data at CROI for the phase 2 clinical trials, and phase 3 will be upcoming in the future. Phase 2 looked great, but again, we don't evaluate, the FDA doesn't evaluate approvals for phase 2, so we have to see phase 3. So stay tuned for that.
I'm still curious. Now we're getting all these different ones. Mm-hmm. What are the patient populations for each that you're thinking? Like it's like a wealth of...
Yeah, and so I think first and foremost, we have to talk about access. Because if someone is not able to get their medication within their state, we do see significant limitations in multiple states across the country in different ways. I'm very, very fortunate in my home state of Pennsylvania, where we haven't had significant cuts. But if a patient can't get the medication overall, then it treats the provider and not the patient by prescribing that agent. But when we talk about how we can use these options, let's just say if access wasn't an issue, we can definitely say in the way that doravirine, islatravir, and bictegravir, lenacapavir were studied. These were people on complicated multi-tablet regimens, again, with multiple potential comorbidities. But I want to make it sure it's very clear that neither of these regimens, and they're not the first, that do not have activity against hepatitis B as well, which some of our other regimens in HIV do have. So it depends on the patient population that you treat. If your patient is either living with or is at risk for hepatitis B as co-infection, we may not want to take them off of that, tenofovir-based regimen. But I will say, which is super important, that I would tell my learners or anyone that came to the talk, if you will, that if your patient doesn't have protection against hepatitis B, vaccinate. This is our opportunity that we can give them that protection. And the BeeHive study, which was from last year, if you will, showed us that the recombinant hepatitis B vaccine was excellent, even among people with lower CD4 counts.
Do you want to talk about updates in PrEP?
Sure. So I think at this point in time, I was mentioning before that we're in a bit of an arms race. So what we're seeing in terms of our different options that we have oral PrEP, and then we have two kinds of injectable PrEP at this point in time. And so updates from the oral PrEP space, we saw the follow-ups from the Prevenir clinical trial. This is actually a clinical trial that's been going on for quite some time. They had 90 months worth of data, but we had that data before. And we knew, because this was essentially a self-selection study of oral daily PrEP versus on-demand PrEP using TDF-FTC. And so what was nice is that the patients self-selected, but they ended up self-selecting into about a 50-50 split. And they could choose to switch between the categories if they wanted to. And what was also nice is that through 90 months worth of data, it didn't really matter that they ended up flipping back and forth at about the same rate. They found across the board, which was data that we knew, very, very, very low rates of new HIV acquisition. What they found that was new was an overlay from public health data from the city of Paris, where ANRS Prevenir was done. And they found that despite the fact that this intervention of oral PrEP worked, and we knew that oral PrEP was able to decrease new HIV acquisitions, it didn't really make a dent overall in new HIV acquisitions in the city of Paris. It was a very, very small, minuscule, if you will, decrease in new HIV diagnoses. And when they were able to parse that out a little bit further, they found a significant decrease in new HIV acquisitions among MSM, or men who have sex with men, who were born in France. But this was offset by significant increases by MSM who were born outside France, as well as all comers of transgender women. So to me, what I see that this speaks to is that PrEP works if we can get it into the hands of the most vulnerable in an equitable fashion. I'm not French. I don't profess to know the French healthcare system, but that's a generalized healthcare system that everyone can have access to. But that doesn't necessarily mean that everyone does have access in the ways that they may need. So we need to make sure that we are educating about PrEP, especially in vulnerable communities, reducing stigma, and making sure that providers are able to give it, again, in an equitable fashion. For injectable PrEP, we see in cabotegravir is currently being studied with the Extend 4M clinical trial. So we're going from 2 months to 4 months. Lenacapavir is being looked at to extend from every 6 months to once a year. That's the Purpose 365 trial. But we're going to be, awaiting those results. One additional development is that Merck is currently displayed a very early clinical trial, a very early study looking at a dose selection for once monthly oral PrEP. And that is going to be studied in the Expressive clinical trial program. I always want to say Expresso, it's Expressive, which is currently ongoing. And so we will give patients options, which I think is just really, really beautiful to see.
Maybe before we end, I would like to hear a little bit about long-acting treatment.
Sure.
So what is the data saying and how is that playing out in the real world?
Okay, so what we have so far is one fully active and currently fully approved long-acting injectable treatment for HIV. That is the combination of cabotegravir and rilpivirine. And right now it's being given either every 1 month or every 2 months. And it is of note that the Quattro clinical trial is about to kick off, which would potentially look at this regimen in an every 4-month fashion. Stay tuned, it's a little bit further down the pike. It's just starting to kick off. But what we have seen so far is that uptake really is dependent on where you can have access to it. Because we're seeing different states, different AIDS drug assistance programs limit access and limit our options for patients. But what we do know and have seen in patient-reported outcomes is that people really like this option if they can get it. Because it comes down to those different things that we as clinicians can't necessarily measure. What about stigma in your community? What about if you have a busy life and you just can't remember to take your pills every day? This is a really great option for patients, and we need to make sure that we meet patients where they are.
And what about lenacapavir? Because it's more drug-resistant disease, right, that it's approved for?
Yes, so lenacapavir as well is currently only approved in heavily treatment-experienced patients. There have been some case series, for people who have significant resistance to maybe either cabotegravir or rilpivirine, and potentially off-label using those two together. It needs to be studied in a proper clinical trial format, but we need to meet patients where they are, and you may have to do what you have to do. But we are seeing more lenacapavir usage. We're seeing it again, like I said before, in an oral format coming up. This medication is really here to stay.
Dr. Koren, thank you so much for taking the time to talk to us.
It's my pleasure.
Don't forget to like and subscribe so you can catch everything from Infectious Disease Special Edition.